myself and Dr. Cuddy Singh are going to be here to talk to you over the next hour about transthyretin cardiac amyloidosis, about integrating new paradigms into cardiology practice. So we're partnering with Peerview and the Mended Hearts, and we'd like to thank them for their support. There's a pre-event survey, so if you can look at that. And there's going to be polling during this, so please take part in this. Also, we ask that any questions are submitted through the Q&A, and I'll show you that with the QR scan. And I think we've also our virtual audience, so welcome to our virtual learners. And again, please respond to the polls on your screen and enter questions in the chat window. So here's that QR code for those of you who want to take part in the polling. We'd appreciate it. And also, if you've got any questions, we can put them up through using this. And also, we'd like to say peerview.com has a lot of amyloidosis-centric support. So please don't hesitate to look online and look at all these different supports. And as well, we heard about Mended Hearts, which is a great resource for providers and patients. And again, they have some great discussion guides and resources to use when discussing this with your patients or to give to your patients. I know my patients absolutely love when they get any kind of literature after their visit that they can go home and digest later after the information overload that they often get in clinic. So our goals for today during this presentation is we're going to learn about ATTR cardiomyopathy and its systemic effects, the importance of screening for monoclonal gammopathy or abnormal proteins, and that really the importance of tissue biopsy. And then we're also going to discuss disease-modifying therapies. So I think what's always key about this disease is delayed diagnosis. And this is just one study of many, and this is from the VA, just showing how long these patients have their symptoms for before they start a diuretic, hospitalizations before they get diagnosed. So it's really prevalent. And just this week in clinic, I saw 2 new patients, Friday and Tuesday, both who had gone just through multiple tests, multiple delays, things kind of being, amyloid being suspected but not really being acted on that quickly, like kind of being mentioned in an echo report and no one really doing anything about it. So it's really just something that as soon as it's mentioned, you just want to start down that diagnostic algorithm and go through the diagnostic algorithm to completion. And I think that's going to be one of our key messages today as we go through this. So with this, and we're keeping on time, I'm very privileged to introduce my close colleague, Dr. Cuddy Singh, and she's going to give us a review of ATTR pathophysiology and its clinical presentations.
Well, thanks, Sarah. I appreciate it. So I think overall, it's good to understand that more than 95% of the amyloid that involves the heart, it's either ATTR, which is like wild type or variant, or it's light chain amyloid. The A is for the amyloid, and then the acronym that follows is really the protein that's misfolding and forming the insoluble amyloid fibrils. When we talk about light chain amyloid, it's a complete different disease entity. We're thinking bone marrow, we're thinking multiple myeloma, plasmacytomas, some lymphomas that are then causing these plasma cell dyscrasias. And then the light chains, they deposit and form amyloid fibrils. The treatment for it is chemotherapy. The important reason why we talk about it is when we go down the diagnostic pathway, the advanced imaging diagnostic pathway is truly of high specificity in the absence of light chain amyloid. Now, the most common amyloid that we talk about within cardiomyopathy is wild-type ATTR. So we don't exactly understand why, but hair gets gray, skin gets loose, certain proteins just change behavior as we get older. The old name for it was like senile systemic amyloidosis, but wild-type ATTR happens because this tetrameric protein, which is called TTR, it's a transporter of thyroxine hormone and retinol, which is vitamin A. So transthyretin, predominantly made in the liver, a little bit in the retinal epithelium choroid plexus. This tetrameric protein, due to the aging process in wild type, it starts breaking down into monomers, dimers that then clump together and form these insoluble amyloid fibrils that then cause a systemic deposition disease, cardiomyopathy being a part of it. Now, if it did not happen due to the aging process, but it was like a gift from your parents, so you were born with a genetic mutation, typically heterozygous, so one of your TTR gene alleles was mutated there are more than 130 known mutations, then the same process happens, but we do know that variant is a more unstable tetramer that progresses faster compared to wild type. And then there are more than 130 new known mutations within this TTR gene already. And as you can see over here, some of them are more neuropathy predominant, and then some of them are more cardiomyopathy predominant. But a large number of patients may present with a mixed phenotype. So they do have an overlap of signs and symptoms, and certain mutations make them more predisposed towards having one phenotype. The other call out, I think, in terms of nomenclature is important, because when we get these genetic testing reports, the V122I may now be labeled as V142I, and that's because it's the DNA, then it's the protein location, because a new 20-proband protein was discovered. So the V142I, we mean it's the V122I mutation, but the T60A now is T80A, kind of so on and so forth. So I think that's important nomenclature to understand in this patient population. And then overall, if you see the certain mutations, they lie within certain ethnic subgroups or within certain geographical locations. So the most common in the US is the V142I mutation that is present in 3 to 4% of African Americans. Not everybody that has the mutation gets the disease. So there's this concept of penetrance, right? So what is your likelihood of getting the phenotype if you have the genotype? So the penetrance of V142I is variable, kind of 1/3, around like 34.7% of patients who have the mutation will actually manifest disease. The T60A or the T80A has now been described kind of more like a perfect mixed phenotype, because a lot of patients, they have both cardiomyopathy and a neuropathy. It is one of the more common mutations in the world, second most common in the US. The other one that is one of the most common ones in the world is the V30M, which could be early onset or late onset, predominantly neuropathy, found in more Portuguese, Swedish, and Japanese population. So I think this is a good overview to understand that the patient, depending on the genetic mutation that they have, may present more with cardiomyopathy, neuropathy. Taking a family history, a family chart becomes so important in this patient population. And then the clinical manifestations of ATR, this is by no means an exhaustive chart. As most of you may have seen, some patients may present more with cardiomyopathy, more with polyneuropathy. I think in heart failure, cardiomyopathy, we talk about more HFpEF, but you just got to remember these patients may have more age-related comorbidities as well, such as ischemic heart disease, valvular heart disease. So they may present with HFrEF as well. Arrhythmias, sick sinus syndrome, Brady arrhythmia is more common in general that are present. Conduction system abnormalities, a patient requiring more pacemaker implantations or going into heart blocks, for example, especially after TAVR valve implantation. So those are things to think about. Or intolerance to standard GDMT, especially beta blockers or ACE inhibitors or ARBs, I think, is more things to think about. So if you have a patient with heart failure, you start them on a low-dose beta blocker, and they're coming in with heart block or syncope, that is a very exaggerated side effect of certain low-dose GDMT. So that is something that should make you think about, okay, do they have pronounced dysautonomia at baseline that is causing these exaggerated side effects? And amyloid would be one cause of those. I think musculoskeletal manifestations, especially very common in wild-type ATTR. So, the biceps tendon rupture, that's also called the Popeye's muscle because it pops up. And then, lumbar spinal stenosis, carpal tunnel syndrome, a lot has been published within that. A lot of these people, they have these musculoskeletal manifestations 5 to 10 to even 15 years before the clinical diagnosis of cardiomyopathy. So if you're in your clinic, you're admitting patients with heart failure in the hospital, just glance quickly through their past medical surgical history. And you're like, okay, this is a 60-year-old African-American male, does not look like, plays sports, but has had knee replacements, arthroscopic surgeries, lumbar spinal stenosis, or a young patient with erectile dysfunction. That should make you think, okay, there is something else going on in this patient besides what meets the eye, which is heart failure. The polyneuropathy, it is sensory motor. It's usually a painful paresthesia that may be present. It usually starts more distal, then to proximal, goes from like sensory to more motor weakness as well. I think the more forgotten neuropathy is the autonomic neuropathy. So orthostatic hypotension, gastroparesis, They can have malnutrition, weight loss because of the diarrhea, constipation, bloating that accompanies with the GI symptoms of polyneuropathy, and then with autonomic dysfunction. So a lot of organ systems that are involved. Basically, somebody from the healthcare team has to connect the dots and think, aha, it may be one diagnosis that seem like unrelated signs and symptoms in this patient to initiate the diagnostic imaging pathway. So clinical suspicion is the key. And then I think this is a nice chart just showing you overall the natural history and progression in patients with variant ATTR. So those are the carriers. And then where we go from people with subclinical disease to clinical, where things like LV strain may change before gross LVEF changes, and then how, the LV wall thickness may be a late biomarker, but if you're looking at NT-proBNP and others, then it might be something that you may notice changes sooner. And we kind of went over this slide a little bit more as well. So I think one of your questions in the poll is what is the most common cause of ATTR cardiac amyloidosis in the United States?
Oh, good people have learned. I'd say wild type is definitely the commonest form that we see. V122, although the prevalence of that genetic mutation, or V142I, is pretty prevalent. Again, the penetrance is not that high. So in my clinical practice, probably makes up maybe 10 to 15% of the TTR patients I see. And then kind of 80% would be wild type. Do you experience the same?
Yeah, I would say similar. And then light chain becomes the least. I would say probably 1 in 10 I would see as light chain. And then, kind of ratio of 1:7 or 1:6 to variant versus wild type.
Yeah, and then
very similar.
The T60A or T80A, I've a few patients with that, not many. And actually, V30M, I think I've only 1 or 2 again. Also because, as you mentioned, that can often be a predominant polyneuropathy. And since we do a more cardiocentric program, we don't have a lot of the patients with purely polyneuropathy.
I have like 2 large families of Irish descent that I follow of T60A mutations, so they kind of constitute half of my T60A patients.
two families. Okay, so we'll proceed on, and we're going to talk about diagnostic challenges and practical solutions. So this is very much based on a patient that I looked after. So she was a black woman aged 82, and it was back in 2020 she presented with an anterior STEMI and underwent PCI to the proximal LAD. She had a repeat presentation within a few weeks of chest pain, and they repeated her left heart cath, and they didn't find anything that kind of notable. At that point, stents were patent, but they did an echo and an MRI kind of as workup for this ongoing anginal chest pain post-PCI. What was also noted in her history was she did have a history of spinal stenosis and recurrent falls, as well as ischemic heart disease. So here's her echo, and this is kind of a real-life image, and hopefully it'll keep playing on the loop. So this is her apical 4-chamber, kind of LV-focused view. And as I said, she had a history of this STEMI, so we can see that the septum is kind of akinetic, markedly hypokinetic, but there's increased wall thickness, which is kind of marked there. Now, you don't look at this, I look at a lot of amyloid echoes, so sometimes my eyes are kind of skewed. But if someone showed me this across the room, I don't think I'd say, oh yeah, that's amyloid, I think I'd probably say, oh, recent STEMI, a history of hypertensive heart disease, that might explain it. But I don't think much went into the echo report saying, like, think of infiltrative cardiomyopathy here. I think they were kind of focused on the wall motion abnormality. But the patient went on to have an MRI, and the MRI was done actually kind of prior to going back to the cath lab, and it was a stress perfusion MRI, because our center does a lot of relatively does a lot of stress perfusion MRIs. And here you have the still image. And this is an LGE, so late gadolinium enhancement image. And some people say, oh, can you not put up a better image? This is a presentation you're giving. But this is kind of what they can look like. So you can see, if the pointer works, when we have this diffuse gadolinium enhancement, it can be really hard to tell the blood pool from the myocardium. So I can't tell you the amount of MRIs I've read from maybe centers that don't see a lot of cardiac amyloid, where they say LGE was insufficient quality for a read. And I'm like, oh my God, it was amyloid. It wasn't bad quality LGE imaging. It was really hard for the MRI technologist to null the myocardium. So they kind of said, oh, there was something funky going on, I couldn't null. And this is very classical, like transmural LGE, but in some cases we see kind of a diffuse subendocardial LGE or more heterogeneous LGE, and that's definitely where I've seen a lot of reports say, poor quality LGE, uncertain, and I'll say, no, that was amyloid. And then we're not going to talk about it too much, and at this stage I don't think it was done, but now doing T1 mapping and extracellular volume, that's kind of pretty much universally available. But again, that's something that I often see is done on outside scans but not reported, and it can be a really nice way to kind of verify what you're seeing with the LGE if you get an ECV value. And I have done so many of these that I would suspect this would show an extracellular volume in the 50s or 60s, looking at this kind of LGE pattern. And luckily it was noted, and they said, think of amyloid. So the patient was referred for an outpatient PYP. And at this stage, we'll go to our diagnostic algorithm. So clues from history, ECG, or imaging. Well, really here we have the clue from the MRI. We have a really classical diffuse LGE picture in an 82-year-old black lady with a presentation with chest pain, so not maybe that typical at this stage. So the next part of the testing, again, is the monoclonal protein. So it's so key to do the complete workup for this, which is the serum-free light chains, as well as serum and urine immunofixation. And multiple studies, but especially a really nice one from the Mayo Clinic, shows that if you do all three, you're highly unlikely to miss any light chain amyloidosis. But kind of some labs would say, oh, we'll start with the SPEP, just the protein electrophoresis, and we'll only reflexly do an immunofixation if that's abnormal. And that can definitely miss a somewhat 5 to 10% of monoclonal gammopathies. So it's really key that immunofixation is being performed, and as well the serum-free light chains. Serum-free light chains is something that people's eyes glass over when I start to talk about interpreting them relative to renal function. So I think if you're not comfortable, talk to a colleague who is and find a friendly hematologist, because it's so key to working up these patients. In the case when there's an abnormality, again, be quick to call a hematologist and be quick to get a biopsy. And especially people think, oh, I need a bone marrow biopsy. You actually really need an organ biopsy as well. The bone marrow is just to look for a plasma cell volume, plasma cell dyscrasia. You really don't expect to see actual amyloid in the bone marrow, and if you do, you're lucky. What you really want to do is look for amyloid deposition in an organ. So some centers will go for a skin or fat pad, and then other centers will say, we're going for the target organ. And often that can just deal with what your access is to getting an endomyocardial biopsy, which pathologist you work with more and have more confidence in making the diagnosis. If you're not worried at all, the immunofixation, serum-free light chains have all been reassuring, then you can go down the non-invasive pathway and get radionuclide scintigraphy with the bone avid radio tracers. And here, this is adapted from the AHA, ACC recommendations, and we say that they see if it's negative, cardiac amyloid unlikely, and if it's positive, then highly likely and very much specific for a diagnosis of ATTR cardiac amyloidosis. So again, this is kind of going over what we need to make that non-biopsy diagnosis. So you really need the appropriate clinical suspicion. The kind of older patient, often with a cardiac presentation. And what was key about the paper that validated the bone avid radio tracers for the diagnosis of ATTR cardiomyopathy was all those patients in that study of 1,500 patients had typical echo or MRI features. So where I really see sometimes bone scintigraphy fall down and people say, oh, like I'm getting false positives, you need to have like a high degree of pretest probability. So you should have an echo that has somewhat typical features or MRI that has somewhat typical features, not to be sending 8mm wall patients for PYP. So positive scintigraphy and then the absence of a monoclonal protein. So she went on to have free light chains and they were slightly elevated but with a normal ratio. And we look at her creatinine at that point was 1.5. So adjusting for that EGFR, that light chain level was not concerning at all. So we kind of put that to bed. Serum protein electrophoresis with immunofixation showed no monoclonal gammopathy, and the same for the urine. So she went on to have a PYP scan, and we can see it here. In our center, we do SPECT with CT. We have never read off planar, as far as I can recall. I think this was just one loop, so I'll go back and see if I can play it again, yeah. So here we can see that this is all blood pool. And you can imagine if you might have only taken planar, you might have seen some kind of hazy activity in the area of the myocardium. But we can confidently say here that was all just blood pool activity. So with that, I'm going to leave the case there, and I'm going to let you guys decide what would you have done next. Would you have gone and said, okay, PYP negative, I'm going to park it, monoclonal gammopathy negative, I'm going to park it there. So think about that while I hand back over to Vasvi.
That's a great case. So a slightly different case. So this is a 62-year-old white male. This is one of my patients. He had a recent admission for acute decompensation of HFpEF, and then after that he was sent for cardiology evaluation as an outpatient. He was in, he had evidence of residual heart failure when he saw me in clinic, some dyspnea and exertion, but also, like, interestingly, he did not volunteer these symptoms. But when we asked, he had more neuropathy symptoms of tingling, numbness, and painful paresthesias as well. He had actually lumbar spinal stenosis, for which he was getting back injections as well for pain. And then in his labs, when we look at his NT-proBNP was obviously elevated. He had a heart failure admission. But even after discharge, his dry euvolemic volume had an elevated NT-proBNP and then high sensory troponin. He was otherwise obese. He had some non-obstructive CAD. The peripheral neuropathy, he had previously seen a neurologist, but they kind of have labeled him as idiopathic. If we look at his ECG, it's a normal sinus. There's some borderline low to normal voltage QRS, and I think that's one of the pet peeves that I teach my fellows. Hey, if you have an echo that shows increased LV wall thickness, but a normal QRS voltage, you should definitely start thinking of amyloid rather than hypertensive heart disease or hypertrophic cardiomyopathy. So if you look at, however, his echo, he had normal LV and RV wall thickness. This is a parasternal long axis view. And then you can see it playing over here. The aortic valve looks fine. It's just mildly sclerosed. There's a mitral annular calcification. So nothing overt, right, in that parasternal long axis that you would think, okay, this is amyloid heart disease. But then enter strain imaging. So, strain imaging amongst the echo indices is one of the higher ones that has a higher AUC for suggesting amyloid. It's obviously not a perfect metric with an accuracy in about like 70 to 80%. And then kind of we have published on it too, like if you have CKD, it may reduce your specificity even more. But this patient did have a reduced global longitudinal strain of -12% in the presence of a preserved EF. And then if you see, he has this cherry on top, or apical sparing strain pattern that is frequently seen in cardiac amyloidosis, but you can have amyloid without an apical sparing strain pattern. I think that's important to say. So having those findings, and then he had heart failure, and then he had neuropathy symptoms, we were thinking, okay, could he be a variant kind, maybe with mixed phenotype? So we went ahead and started the diagnostic pathway for amyloid. So the number one thing is we ruled out light chain with serum and urine immunofixation, serum-free light chains. It was completely negative. And then if we look at this, so I put a SPECT-only scan here just to show how challenging it could be to pick up focal uptake if you're not a reader who's read a lot of focal uptakes. And a SPECT CT would make this reading so much easier. So it increases reader confidence and accuracy and reproducibility of reporting. So the planar, which is, if you look at the HCl ratio, it was negative, right? And then, however, if you look at these chest recons in the axial view, you can see a little bit of some positivity that looks like maybe it's the interventricular septum, but this definitely warrants further investigation. And just to point out, if within your system you have a SPECT CT and SPECT, the amyloid patients should be sent to a SPECT CT system because focal uptake, as you can see, can be difficult to determine. We did order a cardiac MRI for this patient next, and these are Cine SSFP, or steady state free precession images. And then you can see the 4, 3, and 2 chamber. Again, the LV wall thickness looks good, the RV wall thickness looks good. The right atria is a little bit dilated. But as we were talking about, ECV is so helpful in these cases. So if you look at it, if you look at the scale, as you're going from like green, blue to more like yellow and red, that's elevated ECV. So this patient, you can see a little bit more red and yellow in the septum area compared to others, but overall, he had an elevated ECV, I think about like 30 to 35%. Usually we talk about a diagnostic number of 40% when we're talking about amyloidosis. However, it is an abnormal ECV. Normal would be like in the 20s, early to mid 20s. And then if we look at his late gadolinium enhancement, so these are PSIR phase sensitive inversion recovery sequences, the red arrows point to the LGE, or the fibrosis or late gadolinium enhancement within the septum. So it's very interesting because if you correlate it with the PYP or HDP imaging, it's kind of showing the maximum uptake of the LGE as well as the ECV in the region of the septum in a patient who had normal LV and RV wall thickness. But we were able to pick it up because of clinical signs and symptoms, but also apical strain pattern or reduced global longitudinal strain. So I think in addition to having clinical suspicion, we are fortunate in the era of AI-driven algorithms. There are so many, and this is a list of few over here, that are using 12-lead ECGs, echo parameters, strain imaging, and many EMR crawlers that can help you give a nice AUC for people for detecting cardiac amyloidosis. And I think more and more systems are adopting these systematic screening pathways outside of clinical screening pathways. So I think that's important to understand, and this is one of them, a TrackNet, that in this screening criteria, about like 48% of patients had ATTR cardiac amyloidosis, and then you would go ahead and do the advanced imaging diagnostic pathway using tools such as this. And then this is a list of like other things that are going on that are being presented in ACC along in the similar topic. So, I would encourage you to go and visit these poster sessions to kind of dive more into using AI-based technology for differentiating people with what we call the thick heart conundrum. So hypertensive heart disease, hypertrophic cardiomyopathy, or amyloid heart disease, amongst other things. So another poll question. So in a patient with suspected ATTR-CA, which test may be optional?
Give people a second to think about this one. Oh yeah, I think I agree with the audience.
Yeah.
So definitely sometimes the problem I see with CMR is it just delays diagnosis if you don't have access. And I've seen a few times where people said, oh, I thought of amyloid and I'm getting a CMR. And I'm like, did you not think of doing the light chains first before you waited 8 weeks to get a CMR? We could have really had the ball rolling on hematology biopsies before we got a CMR. I don't know if that's kind of, you've seen that much.
Oh, absolutely. Yeah, I think like that patient was different, right? Because he was more early amyloid, and then you have to, and we'll see about what happens next with him. But a vast majority of the patients, you do not need to perform cardiac MRI. You just need to get them expedited so that you can start treatment early. And so a PYP and then one-time non-fasting blood work and random urine sample is literally all that is needed in a patient that you're clinically suspecting and has morphological features on, for example, an echocardiogram for amyloid.
Yeah, I think we've both shown in both our cases the utility of MRI, but it's just not essential. Okay, so evolving therapeutic approaches. So we're back to my patient 1 year later. She's continuing to be admitted with recurrent hospitalizations for heart failure. It's noted very sensitive to fluid fluctuations. Again, one of the red flags you noted, that often patients become overloaded quite quickly, but at the same time, over-diuresed quite quickly as well. On a lot of meds, so labeled at this point with heart failure with mixed etiology, kind of they said like a HFpEF hypertensive heart and ischemic cardiomyopathy. More admissions, again, part of this is also recurrent falls in the setting of spinal stenosis. During one of these admissions, a PET scan is done and there's diffuse microvascular dysfunction. So again, people are thinking, oh, it's this like older woman with HFpEF microvascular dysfunction. Even though we've shown many years ago, microvascular dysfunction is a real feature of cardiac amyloidosis as well. Also goes on to develop paroxysmal atrial fibrillation. So back to the algorithm, and as I mentioned, this had kind of said radionuclide scintigraphy, no, cardiac amyloidosis unlikely. But if we go to the European guideline, and I'm not just saying this because I'm Irish, but I do think this is kind of a little bit more clinically useful, because if we follow this down, I'm going to use my pointer, scintigraphy grade 0, hematological test negative, AL unlikely, but if suspicion persists, consider CMR followed by biopsy. So this lady did have a CMR, and the CMR was classical, so this buys her a biopsy. And it was only like, as I said, 5 years later, one of the inpatient attendings came to me and said, should we really be doing a biopsy? And I was like, yes, like this person has potentially a treatable disease. You should absolutely be doing a biopsy. So that's what we went on to do. We went on to do a biopsy and it showed transthyretin amyloidosis, no variant peptides, and we also did genetic testing, which was negative. And this is what I've heard one or two people kind of say, oh, an older black patient, if the genetic test is negative, maybe we don't need to go further. But wild type is very also prevalent in our older African American, Hispanic, Afro-Caribbean patients as well. So we can't just use a genetic test as a screening tool. So she went on to be diagnosed with ATTR cardiomyopathy. So we do see some kind of false negatives. It's not common, but we do see it, more so in early disease, but this was unusual. But also what I'd point out is we also see non-AL and non-ATTR amyloidosis. And even though for those rare forms of amyloid, unfortunately we don't have treatments, it's still important to make that diagnosis so that we know what the patient is dealing with. And then Vasvi, I'm going to pan back over to you briefly to say how you approached your patient with the focal uptake.
Yeah, so, with our patient, we sent him for genetic testing because remember, he was like younger, he was also of Irish descent, and he actually came back positive for a T80A mutation. When you actually go back and then you talk to his family, remember one of his sisters who was in Florida actually had pacemaker implantation a couple of years ago for unknown reasons. And then there was another family member that then subsequently became my patient because she was also positive for the genetic mutation. So I had a discussion with the patient. I said, hey, your MR is strongly suggestive of a cardiac, amyloidosis. And then you did have this like focal uptake. You clearly have had heart failure admissions and many other signs and symptoms. Typically, we would go directly for an endomyocardial biopsy, but he was apprehensive. So I said, okay, how about we do a fat pad biopsy? We'll do a core biopsy. You have to understand that if it's negative, especially the yield in hereditary is about like 30 to 40%. It's the best in light chain, but that's 50 to 60%. The yield is the worst in wild type, which is like 20, 30% range. So I said, hey, if it comes back negative, we will have to do endomyocardial biopsy. But he came back positive. So he came back positive for the fat pad biopsy, and we sent all of our positive cases for Mayo for mass spectroscopy, and then that came back positive for ATTR. I do have to say, if he was he was initiated on treatment for mixed phenotype, neuropathy, and cardiomyopathy. I do have to say, if this was a patient with light chain amyloidosis, I would fat pad biopsy. I would straight go for where the money is, because time is of the essence. So if this was a patient that I was working up for light chain, we would do endomyocardial biopsy so that you can start them on treatment early, because untreated light chain cardiomyopathy has a prognosis of 3 to 6 months. So, but because he was TTR, I'm like, okay, let's just try fat pad and then we'll go from there.
Yeah, that makes sense.
Yeah.
Okay, so back to kind of treatments and what we think of mechanisms. So as Vasvi pointed out at the very start, what we're trying to target is the precursor protein. So the protein that's misfolding and forming the amyloid. So in TTR, what we want to target is that TTR tetramer. And we can do that at different parts of this pathway, either at the level of the liver or targeting the tetramer itself when it's in circulation. Similar when we go on about light chains, what we're ending up targeting is the plasma cell that's producing the light chains. So there's this very nice model presented by Mariana Fontana about how kind of treatments are working at the moment. And really what we're kind of doing now is hoping that we're kind of reducing the amount of breakdown. So we're just really at the point where we're kind of slowing the disease trajectory. We haven't, unfortunately, got to the point where we can start to remove what's being deposited and reduce the burden. So really our therapies at the moment, especially in TTR, are kind of focusing on reducing new amyloid production. So we have 3 FDA-approved therapies for ATTR cardiomyopathy. So that's both variant and wild-type cardiomyopathy. There's more for polyneuropathy, but we're focusing on cardiomyopathy today. So we have stabilizers, as I mentioned, they stabilize that TTR tetramer, tafamidis and acoramidis. And then we have one silencer that's been approved, vutrisiran, and that acts on the level of the liver, a small interfering RNA, to knock down production of TTR at that level. So if you've less precursor protein or a more stable precursor protein, you've less amyloid production. So very much different administration. The stabilizers are oral tablets that are either 1 once a day or 2 twice a day, versus the silencers, and vutrisiran is a subcut injection once every 3 months. So sometimes that's the first thing I say to patients, and they'll make up their mind purely based on dosing regimen. And they're kind of like, you've told me enough, doctor. I know which one I want. So sometimes that can be as far as you need to go in the patient discussion, or sometimes we really have to get really more nuanced, depending on how much kind of patients want to know about each. So for cardiomyopathy, the stabilizers have an indication, but not for polyneuropathy. But the silencer, vutrisiran, does have an indication for polyneuropathy as well. So that's something to consider again in our variant patients with the polyneuropathy as well. I didn't actually spend time on the side effects, but these are very well tolerated drugs for the most part. So which one is better? This is kind of impossible to say. So here's a table comparing the 3 trials: ATTRACT for tafamidis, ATTRibute for acoramidis, and HELIOS-B for vutrisiran. Oh, sorry, I thought I had a box highlighting something. So first of all, if we think about the 3 trials, ATTRACT, ATTRibute, HELIOS-B, they recruited at very different times. So ATTRACT recruited 2013 to 2015, versus ATTRibute and HELIOS-B started recruiting 2019 through 2020, 2021. If you think of the patients we were seeing back in 2013 and 2015 with amyloid, it was really only being diagnosed when I think was very much advanced disease, textbook cases, versus the cases that we're diagnosing now, which are much earlier in the disease progression. And we can see that as we go through the table. The amount of patients with NYHA class 3 was much higher in the ATTRACT study versus ATTRibute and HELIOS-B. Similarly, that's reflected in the median NT-proBNP, which is highest in ATTRACT, followed by ATTRibute and then HELIOS-B. And similarly, that's reflected in the NAC stage, which is biomarker stage, combining NT-proBNP and EGFR. So again, we see a lot more advanced patients were recruited into the ATTRACT study of tafamidis. So we see that definitely the placebo group, which is the lower of these curves, had the worst outcomes. And this is where we still talk about that kind of rapid disease progression, median survival of 3 years with this disease. But what's been so exciting is the shift of these curves with each trial. So we can see that the treatment arm did so much better in ATTRACT than the placebo arm. But then again, when we come to attribute the next one up, the placebo arm did even better than the treatment arm in ATTRACT. And we can kind of pretty much say this is really due to earlier diagnosis and probably somewhat maybe better heart failure management of these patients as we learn more about the disease. But we're really shifting these curves up. Again, very effective treatment for all-cause mortality and CV hospitalization. And then similarly with HELIOS-B, again, we see this placebo arm is higher again than the treatment arm of the other two trials. And we can see here the treatment arm in this trial, we're nearly pushing towards age expected mortality, which is highly exciting for these patients who sometimes Google stuff and come in and think, oh man, do I have 3 years to live? And you can say confidently, like on treatment, we can prolong survival and prevent hospitalization. And that's often one of the key messages when patients start to get into the weeds about what drug, which one's better. And I'm like, do not worry, all these drugs work to prolong survival and prevent hospitalization, and that's what we're here to do for you. And I think the patients take a lot of reassurance from that, and that's just kind of showing this in these slides. Also, what's very key for these patients is you can tell them that these treatments have also been shown to maintain quality of life, to prevent like a deterioration if you were on placebo. So kind of reassure them, you'll take these treatments and this will try and help maintain your quality of life, your functional capacity. Unfortunately, it's not perfect stabilization, but we can kind of guarantee some of the patients a bit of a status quo for a few years compared to when they were untreated, where we'd see a steady deterioration at each clinic visit each 6 months. Now the patients come in to me and say, nothing much has changed, which is such a transformation from like 8 years ago, where I'd come in and I'd be like, right, we'll double your torsemide, we'll do something else. It's a very different way that we're managing patients longitudinally. So combination therapy is kind of on everyone's lips. It makes the patients come in and say, doesn't it make sense if I'd be on two, if one gets rid of the protein and whatever protein's left over, the other one targets? So I think this is a very kind of discussed topic. And this comes from the HELIOS-B trial. And we have to remember a very small number of patients were using tafamidis at baseline. So if we see that's 259 patients, so we divide that between placebo and treatment, we only really have 130 in each arm. So we see a trend towards improvement with combination therapy, but we see very wide confidence intervals. So at the moment, I'm not like, when I see a patient in clinic, I'm not like, we got to get you on everything. One, I'm super nervous if I took that approach, insurance will turn around to me and say, no way. And then I'll have a very anxious patient saying, you told me I needed a combination therapy, the insurance won't approve it. So one, I don't think we have the evidence to show that. But what's exciting is we have more studies coming out, and I'm sure this will be something that we learn more about. So what's been very exciting about all these studies is also the amount we're learning about the disease from the different sub-analyses. So again, at ACC, there's multiple different presentations looking at different sub-analyses of these trials from which we got a lot more disease insights. So look out for those over the weekend. So what's the kind of recommendation about individualizing selection choice of disease-modifying therapies? This comes from the ACC, just published, I think it was published online late last year, but in paper early this year. So if we're looking at disease-modifying therapies, which is like the middle track, we're looking at appropriate for disease-modifying therapy. We want to make sure they're on the correct diuretics and stuff, and I think Vas will go into that. But what they recommend is discussing cost and pay coverage with the patients, access, patient preference. And there's insufficient evidence to recommend TTR combination therapy. And there's also not a lot of evidence about changing therapy if disease progression, and I think a lot of people are trying to collect the real world evidence for that. But then, as we mentioned, if you have a patient who does have variant disease with a mixed phenotype, a silencer is likely preferred at that point at the moment. So what are our criteria at the moment for following disease progression? Well, this was an updated paper that just came out again early this year, led by Pablo Garcia Pavia. And to be honest, this kind of disappointed me because there was no imaging biomarker to track. But unfortunately, that's because we haven't done a good job validating an image biomarker as tracking progression. Like, we look at ECV, but that has not been validated in multi-center trials as a marker to look at over time. Even similarly, GLS. So heart failure hospitalization makes sense. Outpatient diuretic intensification has been validated in large studies. Similarly, NT-proBNP and EGFR validated as markers, and also the 6-minute walk test and quality of life. I actually don't do a Kansas City questionnaire in work, like in my clinical practice, but I do the 6-minute walk and find it quite handy, just to kind of correlate with what the patient's subjectively telling me to something a little bit more objective. So that's it. Even though this paper doesn't mention imaging biomarkers, I'm an imager, so I still really use imaging in clinic. So I use an echo annually. I keep track of the GLS. If something's going on that's just not adding up, then I'll reconsider an MRI. And then I think what we're really excited about, Vasvi and I, because we're both nuclear imagers, is the PET tracers that are in development. And there's a number of different amyloid PET tracers. Most notably, evusematide is a pan-amyloid tracer in phase 3 study that potentially could be something that could be quantified over time. And we talked about MRI. I think it's ECV is an incredibly handy marker, but really probably needs multi-center validation. And hopefully we'll see that in some of the clinical trials coming out later this year that have MRI in their sub-study analysis. So with that, I'll hand back to Vasvi to talk about heart failure medication.
Well, great, thank you. So as one of the people who were on that consensus document, so I think, the imaging biomarkers, there will be, so the paper was about a couple of years old, and then the team mainly looked at what has, at this time, prognostic correlation of data with mortality, with the year points being baseline and at 1 year. And then if you have change in metric with the list that you have of 2 or more parameters, then we are calling it disease progression, and to differentiate disease progression clinically from amyloid deposition. Because we know like the amyloid disease progression can be due to progressive heart failure, arrhythmias, aging just by itself. But I think like an imaging follow-up as we get more data, for example, from the CardioTransform MRI sub-study is definitely to follow. And I'm excited about that. So I think overall, when you look at your patient with ATTR-CM, disease-modifying therapy is key, but you also have to treat them like any other heart failure patient, which becomes key. I think a lot that we see also in the placebo arm, how the survival of the placebo arm actually improved by 50% from ATTR-ACT to like HELIOS-B, which was the latest trial. And a part of it that was the approval of SGLT2 inhibitors as well, and more awareness and starting treatment early. So I would say the first line, is obviously of what we call decongesting the patient. So loop diuretics, many times if furosemide is not working, I do go for higher bioavailability with torsemide. MRA, kidney function and potassium permitting, those are the first line. And then I think most people tolerate SGLT2 inhibitors very well with good prognostic data overall in heart failure. Beta blockers, they're tough. We may give it a try if they are HFrEF patients especially, but you just have to remember these are people with remodeled small LV cavities with kind of like a fixed stroke volume index. So they do rely on resting tachycardia to maintain a cardiac output. So therefore, they may not be able to tolerate beta blockers as well. And a similar, they have a preload dependence. Therefore, vasodilators, such as if you have like ACE or ARBs, may not be as well tolerated. So I would say, you start with your loop diuretics, you do your MRA, SGLT2 inhibitors. If they do have HFrEF, you may consider doing very low doses of beta blockers, ACE, ARBs, just understanding that they may have much more exaggerated adverse effects compared to any other patient population. Atrial fibrillation, obviously, it's a sinister event in the life of any heart failure patient, but especially in amyloid heart disease, because the restrictive cardiomyopathy gives them really a diastolic dysfunction. So, when we look at all of our echocardiographers, the E and A waves, they really rely on the atrial kick. And we know that people who have diastolic dysfunction, 1/3 of their cardiac output can be derived by the atrial kick, which if they lose, then because the E is not good because of diastolic relaxation, they truly go into flash pulmonary edema. So that is just something also to understand in this patient population, that AFib does contribute a lot to morbidity. And then CHA2DS2-VASc score is irrelevant. They are hypercoagulable, just like in hypertrophic cardiomyopathy. If they have AFib, you have to start them on oral anticoagulation. And that's kind of overall what we went through already, the different classes of medications, especially the SGLT2 inhibitors, they have shown some benefit in this patient population, and this is one real-world study for tafamidis with GDMT and heart failure showing lower risk of all-cause mortality and other MACE events when combined with other heart failure therapy. The other thing is like the GI manifestation. So, they can be non-specific, but truly affect the quality of life because of bloating, nausea, vomiting. We know malnutrition and accompanying sarcopenia is a big problem with heart failure patients, but it really gets exaggerated in the amyloid patient as well, because one, you have your increased hydrostatic pressures because you're in heart failure, but you also have decreased oncotic pressures because they may have protein-losing enteropathy now, or they have nephrotic syndrome because the kidney disease had advanced. They have bloating, so they're not able to have a high-caloric, high-protein diet. So it's really a multifactorial problem. So really, it's geared towards symptomatic management. So for example, if they have nausea, you may use like prokinetics or other antiemetics. For diarrhea, you may use something like loperamide, and then laxatives, both what we call pushers and mushers within the constipation realm, usually a combination of both of them. And then dietary modifications, I think talking to them in detail about maintaining a good nutrition becomes very important for overall survival and avoiding frailty-related deterioration as much as possible. So we come to our next question. So patients with ATTR cardiac amyloidosis should initiate and optimize all 4 classes of GDMT for HFrEF before initiating a targeted therapy. True or false?
I hope we get the right answer to this. Yeah, we don't want to wait, especially if you say before initiating targeted therapy. We want to start them on disease-modifying therapy straight away with something targeting the TTR protein, and then kind of optimize. I'm a bit slow. I often will do maybe start SGLT2 inhibitor, see how they tolerate that, then go MRA. Again, that fluid sensitivity, because I feel if I throw too many things at one time, I'll dehydrate the patient. They'll come in pre-syncopal for all the reasons we mentioned, yeah.
Yeah, I usually go with my amyloid patients. Unlike my other heart failure, ischemic heart disease patients, I definitely do slow titration. So I would start with an MRA and SGLT2, usually kind of a couple of weeks apart. I usually start with the MRA first just because of cost considerations, but SGLT2, most of them are on it in the absence of frequent UTIs or some other contraindication like that. And then I would add something else as needed.
Okay. So I think I can go through this. So just to remind you that the ACC recommendations are really for comprehensive team-based care in this. So we kind of rely heavily on our colleagues. We're cardiac imagers, so I have to rely heavily sometimes on my advanced heart failure team, and unfortunately also on the palliative care team that work with us, also our neurologists, nephrologists, and pathologists especially, and then my hematologists unequivocally. So Vasvi, I'll hand it back over to you to finish up on how Connor was treated.
Yeah, so kind of alluded to this before. So Connor, remember, he was the guy who had sort of early based on really imaging findings, but he had presented with heart failure neuropathy symptoms already. So he was initiated at that time. This is pre-Helios B era. So he was actually started on ATTR polyneuropathy with eplontersen, and he was in tafamidis at that time. ATTR, this case is about, I think, 3 years old. And then at this time, you would have other options as well. And then he had no children. His parents were deceased. And then, that was one of the sisters in Florida who needed a pacemaker for unclear reason. And then there's another sister who's now seeing me in clinic. And that's one of those things. Cascade testing is so important when you find a patient that is positive. And then, we talk to the patient, we talk to their family members. Genetic counselor, if you don't have one in your clinic, which is not uncommon, then, the free testing, they usually sponsor more generic genetic counseling as well, that I would say does suffice the purpose in a majority of cases. So just make sure you do cascade screening of every first-degree relatives, parents, siblings, progeny. All of them have like a 50% chance of having the disease because it's inherited in an autosomal dominant fashion.
I think you're next.
Yeah, so that is, what we're talking about. And then, in general, what do we do about patients, non-invasive monitoring that in asymptomatic individuals? So, the asymptomatic variant or the carriers, a lot depends on a per patient basis. So we always talk about, hey, we do annual clinical exams or H&Ps. So you do have to make sure you get a good history and physical on this patient population. And from there, typically, for example, in my clinic, I would do a 12-lead ECG, and I always do echo with strain. Now, depending upon what is abnormal, what kind of mutation runs in the family, what was the age of the youngest family member that was diagnosed with the disease, screening is typically recommended at least 10 years before the youngest family member was diagnosed with the disease. And then with that, depending on what you found, you can go ahead with a PYP or HDP scan, and then cardiac MRI, and then go on from there. How frequent you do testing, again, depends on all of those factors, but some recommendations out there are like for H&P annual physicals, you could do a PYP every kind of 2 to 3 years, and then you could do MRI every 3 to 5 years, understanding what is the age and which is the mutation, because you also don't want to burden patients with a lot of imaging and testing over time. It kind of went.
Yeah, I think this is kind of highlighting that this is an exciting space. So I talked about 3 FDA-approved therapies, but there's lots of therapies still in clinical trial looking at different parts of this pathway. So we're either targeting the liver, and at the moment we have ongoing studies looking at different silencers, but also at gene editing. And then, again, we have the stabilizers that are approved, but then the kind of holy grail is, can we remove the amyloid? So there's ongoing studies of antibodies directed to the amyloid to kind of stimulate the native immune system to try and clear it out, because it's quite an innate kind of fibril just sitting there, that unfortunately our own immune systems, for some people, there's a few lucky patients who generate their own autoantibodies to amyloid that have been written about in the New England Journal of Medicine, which is fascinating. But for the most patients, they just sit there and the body doesn't address it as like a kind of anything that it needs to clear out. So that's the hope with these antibodies, and they're in kind of active, ongoing clinical trial. So with that, we'd like to thank you so much for your attention this morning. Thanks for taking part in all the polls. And as I said, please use the QR code for any questions. I think in the last kind of remaining few minutes that we have, we have 2 minutes. We have a few questions in here. Okay. Some of these are really nice questions. I'm sorry that we haven't had time to answer them. Okay.
We answered a bunch in the talk.
Yeah. So it says something, the echo of the lady you showed, the texture of the septum was suspicious. Okay, really good point. We tried to look at texture visually, and I couldn't agree with myself, let alone agree with my colleague, so to kind of do those statistics. I think if you see it, comment on it, but it's not really sensitive or specific when we've tried to kind of like somewhat quantify it by the eye. Then
I think the other thing, I really liked your MRI, because if you saw that image, the cavity was so dark. Because the gadolinium, the moment it comes in an amyloid patient's advance, it gets sucked up by the myocardium. So therefore, when you're doing cardiac MR protocols for amyloidosis, we start imaging at 5 minutes after giving gadolinium. So compared to other patients where you would do at 8 to 10 minutes. So you also have to realize if you're ordering an MR for cardiac amyloidosis, it is very helpful to put in the indication of cardiac amyloid, because actually the scanning protocol is different that you would do for VT or sarcoidosis and others. So that truly does help your scanning team. Like, we have a separate cardiac MRI scanning protocol where patients, where the technologists know what to do. And then sometimes the first hint that they would be, if they got too late in getting to the gadolinium images, they'll tell you that I cannot null the myocardium, what's going on. And if you get that call from the MR lab, you almost always know it's an amyloid MRI that they're looking at.
Yeah. There's actually some really excellent questions here. I'm going to fire through one or two. My amyloid expert colleagues say that patients present with bicep tendon ruptures have histories like picking up a ball peen hammer, I don't know what that is, and results in tendon rupture. I have heard the most innocuous story. Someone said they were getting out of a hot tub and felt a ping and it was their bicep gone. So something, or playing tennis and their bicep went. So it can be something very like kind of low key that pops their bicep. A really important question. If on SPECT imaging at 3 hours, heart contralateral ratio is around 1.3 or 1.4, and qualitatively no uptake in the myocardium, how would you report it? We do not go near heart contralateral ratio in our lab. We have not used contralateral heart to lung ratio, heart contralateral lung ratio in at least 8 years, if not longer. We purely report the visual myocardial uptake, saying it's either grade 0, like negative scan, grade 1, equivocal, grade 2 or grade 3 positive. So we purely just go off the qualitative view. We do not go near heart contralateral ratio. As I think exactly like this, the amount of patients that have been referred to me and said, oh, heart contralateral ratio was 1.3, but SPECT was negative. Well, the ASNC now, the American Society of Nuclear Cardiology, really have kind of pushed heart contralateral ratio down in the recommendations, and it really should not be used to make the diagnosis. Potentially the one use is if you have a grade 1 equivocal scan, they can say you can use heart contralateral ratio in that circumstance, but we never use it. I would never recommend using it. Just purely go off your qualitative view.
Also, like on visual, when you're reporting on SPECT, the term equivocal confuses people. That is commonly used in the community. Nobody knows what that means. Does that mean the patient has to come back? Did the radiotracer dose infiltrate? Is the processing wrong? Is it positive? Is it negative? What does that equivocal mean? So what we would say is describe the uptake the way you're seeing it. So if it's uptake, diffuse uptake in the LV and in the RV, very good. This is positive. For example, my case, Connor, he had uptake in the septum. Describe that you're seeing grade 1, grade 2, depending on the intensity when you compare it to the ribs, and this is the uptake that I'm seeing. Any uptake, including grade 1 uptake, is abnormal and warrants further investigation. And 2 and 3 are floridly positive.
There's a good question here. I'm confused about ARNI use. One slide suggests avoid, the next slide said 20% improvement with use. So that's a really good question. I think when patients come in on GDMT, if they're tolerating it, I don't stop it. But if they've any kind of symptoms that I think could be related to an ARNI, such as postural hypotension, I'll drop it. Now, the 20% improvement with use, that's TriNex data. So, very much like these claims-based or kind of federated data where you're not like, you're doing propensity score matching, trying to control for it. So it's very much favoring the patients who tolerate those treatments. So I think there was a very nice paper a number of years ago saying, oh, there possibly is evidence supporting beta blocker use in TTR amyloidosis, especially with the low EF. But if you looked at the type of propensity score matching that was used in that paper, it really kind of the emphasis of benefit is on those who are treated. So if you're tolerating it, yes, it may be beneficial, but it's kind of weighing up how your patient is tolerating it. Because I don't think the evidence is strong enough to say just stay on it, even if you're feeling hypotensive every time you stand up.
Yeah, and then many times, sometimes you may do up titration, and then as the clinical condition changes, you may be taking them off of meds as well. So it's a moving target. I think we answered a whole bunch of them. One of them was like, is there preference or evidence in terms of which one to use first, MRA or SGLT2? I think either or, it depends, like for the MRAs, if you have your kidney function, potassium is good, cost consideration, SGLT2. Usually most of my patients do end up on both, along with the loop diuretic. So either or is fine, it depends on patient preference.
Good question here about evidence of stabilizers in on HFrEF. So amyloid, I think we're always saying, oh, HFpEF, think of amyloid, HFpEF, think of amyloid. We probably need to move beyond that because it's a wide range of ejection fraction. And ejection fraction, it's like we look at it, but it's not that relevant a prognostic marker. It always falls out of any statistical modeling for prognosis. So when we look at trials, the kind of usually mean EF is around the kind of high 40s. So we definitely see patients who range from an EF in the 20s, 30s to EFs in the 60s. So you kind of are a little bit agnostic of ejection fraction. Now I say that, contradicting myself like 5 minutes ago where I said beta blocker therapy might be effective with an EF less than 40% in amyloid. But it's kind of one of those things where we don't, it doesn't matter what the EF is, the treatment approach is still very much the same, addressing the precursor protein.
I think this is a great clinical question. So can you clarify whether or not carpal tunnel or lumbar stenosis should be seen as peripheral neuropathy? I think the answer is no. Musculoskeletal manifestations are different from neuropathy, and you can differentiate the two when you do actually nerve conduction studies, and then, or if you do EMGs, they can tell you if the signs and symptoms, also like the distribution of the neuropathy is different in carpal tunnel versus otherwise no. So they're different. Can they coexist in the same patient? Yes. But if the patient has a sciatica because of lumbar spinal stenosis, well, they have lumbar spinal stenosis. It's not innate neuropathy. So I think that's an important distinction to make.
Yeah. I think we've kind of addressed most of them. So thanks so much for staying till the end and over time. And thanks a million for these brilliant questions. I hope you enjoyed it and got something out of it this morning. I definitely did.
Yeah. Thank you.